over to Don to begin discussing our topic today, which is mental health in the K through 8 setting. Don, it's all yours.
All right. Thank you, Dale. As Dale said, my name is Don Metges, and there we go. There's the screen. So we're here today to talk about mental health 101 in K through 8 students. So we'll be bleeding over a little bit into higher than 8th grade because it covers a range of ages that go from middle school essentially to early high school. But we'll talk about the issues that are that are most common. I'm not going to say fairly common because they're not necessarily common issues, but the most common issues that you might come across in a K through 8 setting with your students, and not just recognizing, but some strategies that you might be able to implement in the school setting. So, again, as Dale said, my name is Don Mitkus. I've been a consultant with Student Assistance Center for the past couple of years, and have previously been a Student Assistance Program Director at a large high school in the suburbs of Chicago. Currently work as a clinical liaison for Alexian Brothers Behavioral Health. So with no further ado, let's jump in. So this might look familiar from your Psych 101 class, Dr. Erickson's stages of development. Just to walk through the first few real quickly and how that might impact students in your building. So from a very early age, the first crisis stage that a person faces is when they're an infant. And the crisis stage is trust versus mistrust. Basically, it's where, if a baby cries and someone responds and they receive food, or they receive comfort, or they receive a new diaper, that their discomfort is being attended to, then they learn to trust that the world around them will attend to their needs and take care of them. Those that don't get those needs met in infancy learn to mistrust others around them very, very early on, which can lead to some fairly significant issues, such as reactive attachment disorder. So these kids have a real difficulty in making connections with other people or developing relationships with other people, because at their core, and their pre-verbal core, they're mistrustful of those that others around them will be able to meet their needs. You see this most frequently in neglected or abused infants, infants in the foster care system, children that have been adopted particularly from other countries where they may not have had much attention in the orphanage settings. And then we move into early childhood autonomy versus shame or doubt, where they start to realize that there's other people that exist around them, and start to develop some form of independence or independent identity from others. And then following that, from ages 3 to 6 is initiative versus guilt. That's around the preschool years, where they're again learning to do things for themselves. If they're not able to pass this particular crisis stage, that can lead to some issues with self-care later on. So here's the ones that are most pertinent to the group we're talking about today, which is stage 4, industry versus inferiority. For our 5 to 12-year-olds, that's when that crisis stage tends that development stage occurs, and identity versus role confusion, which is you'll see in your perhaps with your older students, middle school, 7th, 8th grade, they start to enter into this particular stage of development. So personally, I'm in the generativity versus stagnation period and still working that particular one out. Anyways, so a brief overview of what we'll be doing today. We talked a little bit about the developmental stages, talk about what's normal versus abnormal child development. Why schools? Why is this? Why are schools important in this process of identifying students with mental health issues? Talk a little bit about what the professional community, the psychiatric community says are the diagnostic criteria or signs and symptoms of different mental health issues with kids. And then we'll talk about some common mental health issues, take a look at their symptoms, and talk about some skills to put into practice that might be helpful if you come across a kid in your school or school environment or practice that might be dealing with one of these issues. So one of the things to take into consideration, we're for better or worse, we're a society of folks that like to label things. In schools in particular, we like to be able to labeling students is is helpful as far as getting them the things that they need to be able to succeed in school. Sometimes it goes a little bit, we get a little bit label happy. So asking whether or not this is a mental health issue, is this particular behavior a red flag for a mental health issue? So here's just some things to think about. If a child falls asleep every afternoon in class during a lesson, is that a red flag of a mental health issue? If they're late for school often, if they have frequent suspension for acting out, not following directions, do they have temper tantrums? Are they unkempt? Are these indicators that a child has a mental health issue? Well, there's, the answer to that is forthcoming, but to kind of preface that discussion, we'll talk a little bit about what the developmental goals for bulk of this age group are. So the developmental goals for is K through 6 essentially are to develop industry. So they begin to learn how the capacity to work, develop imagination and creativity, going beyond the scribbles on a paper to actually creating things. Learning self-care, so learning to take care of themselves. They develop a conscience, right and wrong. Right and wrong is is a concept that until they get into really school age, that's not really, they rely on parents to tell them what's right and wrong. During school age years, they start to develop that internal voice of what is right and wrong. They learn to cooperate and play well with others, learning what social rules are and how to interact appropriately with their peers and with adults. So some normal, we all have difficulties. There's no doubt of that. We all have struggles from time to time, but what's normal and what reaches the threshold of clinically significant is part of what we're here to determine today. So normal difficult behavior are arguments with siblings or peers, being curious about the difference. They start to notice that there's a difference between boys and girls and start to explore that curiosity. They test limits. Absolutely, they test limits. That's part of their job at this stage, and that only gets more significant when they move into the next stage of development. They tend to have a pretty limited attention span. That part of the brain that deals with executive functioning is still very, very much underdeveloped at this point. The thing that helps them with attention span. They have worries about being accepted by their peers, which can impact the choices that they make. At this stage they start lying. They start messing around with what is the truth and what they can get away with. And again, that is tied into, this fishtails into the testing limits part of what's normal difficult behavior. they're also very much ready to point a finger at someone else, so they don't have to take responsibility for their own behavior. And these are all things that they're testing out. You know, all kids, well, not all kids, most kids will try on many of these behaviors, which can be frustrating for teachers, can be frustrating for staff, can be frustrating for parents, siblings, peers. But for the most part, these behaviors are normal. These are normal difficulties that a kid goes through. So what are some things, signs that there's some more serious issues going on that might be cries for help, even though they're not necessarily cognizant that they're crying out for help? Excessive aggressiveness, clearly fighting with peers once, twice, maybe a normal difficulty, but being excessively aggressive with others, excessively aggressive in their play with others, serious injury to self or others. And that also includes non-suicidal self-injury. One of the things that we've been seeing is a emergence of self-injury as a behavior in elementary age kids. The organization I work for treats self-injury specifically, and whereas the national data states that the average age of entry into that behavior is 12, for those kids that wind up needing a serious, more structured level of care, such as a day program or inpatient, the average age of entry into that behavior is 8. So it's it's behavior that's been getting younger in age, and something to be aware of is if you do see that behavior, it's fairly significant. Excessive fears, and what we mean by excessive are fears that keep them from engaging in a normal activity for someone their age. So fear of going outside, for instance, or fear of being in crowds or with large groups of people. School refusal and school phobia, refusing to come to school. So if you have a kid that's 20, 30, 40 days absent and calling the parents and they're frustrated because the child's just refusing to go to school, or it's that kid that when the parent gets them to school, you have to peel them off their parents at the front door. That's significant. Fire fixation or fire setting, frequent or excessive or extended emotional reaction. So something beyond a tantrum where that sort of emotional intensity is difficult for someone to sustain, anyone, a child, adolescent, adult. But if those excessive emotional reactions are persistent or continue 10, 15, 20, 30, 40 minutes, an hour, that's significant. Inability to focus on an activity even for 5 minutes, and that's any activity. Kids of this age, of course, as we mentioned before, have difficulty with a short attention span, and that's normal. However, things that they have particular interest in, even if it's not schoolwork, but if there are things that they do have interest in, they normally would be able to attend to that activity for periods greater than 5 minutes or more. So if they're unable to attend to an activity, focus on activity for even 5 minutes, even if it's especially if it's an activity that they show marked interest in, that's significant. Patterns of deliberate behaviors, significant rule breaking, law breaking, risk taking, significant risk taking. Those are all reasons to be concerned and perhaps look at making some recommendations to the family. Adolescents, the cartoon. Adolescents are mysterious. They're going through a lot of changes. They're often difficult. Adolescence starts typically around age 12 and can persist. Adolescence doesn't end at 18. Technically, now we consider adolescence to the adolescent stage development, particularly over the past 15, 20 years, to extend out into the early to mid-20s. So adolescence, the the stage of adolescence is complete when the frontal lobe is done developing and executive functioning is firing on all 8 cylinders. And over the past 15, 20 years, that's been taking longer for our kids to get to, as we're seeing a lot of, not necessarily to this group, but a lot of failure to launch kids in that 18 to 25-year-old age group. So the developmental goals for adolescents is really developing identity. They develop a sense of self and a self-identity and a capacity for intimacy with others. They've gotten to a point where they can think abstractly, and not everything is concrete, black and white, but they have the ability to see the grays in the middle space, and abstract thought develops in this stage. They continue to master the skills from the previous stage of development, as well as accepting responsibility for behavior. They're able to develop friendships, able to follow social rules. A lot of the figuring out how to interact in a social group has been figured out by this stage, and they understand what social rules are, and rules for engaging with their peers and with adults. At this stage in adolescence, they refine those skills. So normal difficult behavior, moodiness, the hormone cascade that's part of adolescence is well known, and you'll see it starting in middle school. They start to differentiate more significantly from their parents, less attention and affection towards their parents, become very self-involved. Peer conflicts are normal. Worrying about relationships and friendships, which although they rarely will tell you that they value their parental relationships and honor their parental relationships, which they do. Externally to the external world, they put forth their peer relationships as more important or primary. Testing limits. This is how they primarily identify and differentiate themselves from their parents, is to test limits and search for the boundaries so they can safely explore who they are. The identity searching, exploring, figuring out who they are. Substance use experimentation, and this is, it's experimentation with things that alter mood. So that could be substance use. It could be self-injury. It could be eating disorder behaviors. It could be risky behaviors with peers, both physically or sexually. They're preoccupied with sex at this age, of course. So there's, in general, part of their search for an identity is to figure out what makes themselves tick, what gets them excited, what turns them on. So that means experimenting with a lot of different things, behaviors, and sometimes those behaviors are not pro-social. So things to look out for, particularly with your middle school group, as far as more serious behavior, that might need intervention, sexual promiscuity or sexual risk-taking, suicidal or homicidal ideations, self-injury, self-mutilation, frequent displays of temper, and displays meaning both significant verbal acting out as well as physically acting out, isolation or withdrawal from usual activities, significant changes in grades, attitude, hygiene, functioning, sleeping, or eating habits. It's meaning, a kid who's normally a B student all of a sudden is getting C's and D's from one semester to the next, that they're not it appears that they're not showering or taking care of their hygiene for days at a time, looking tired or worn out, dragged out, looking like they're losing weight, or have a general look of being unhealthy. Delinquency, so not attending school, rule-breaking, law-breaking, excessive fighting aggression, inability to cope with day-to-day activities, lots of somatic complaints, so those frequent flyers to the nurse's office, complaining of stomach aches or headaches frequently. It just happened to coincide fairly frequently with quizzes or tests or things of that nature. So those that are frequently coming to the counselor's office, social worker's office, nurse's office. So why are schools important in the identification of kids with mental health issues? Some of the answers are obvious, but we'll touch base about them. As this cartoon indicates, kids come to school with not just heavy backpacks, but baggage. And these are these are some of the things that to take into consideration when determining whether someone is dealing with a mental health issue or if they're dealing with some other form of environmental or familial issue. Kids, we don't always know that a kid might be undomiciled or that the only meal that they're going to have that day is their free or reduced fee lunch. That there's food inadequacies at home. So these are that they might be dealing with a particular illness, a chronic illness. Sometimes we have that information, sometimes we don't. But it behooves us when we're looking at a student that's obviously in some form of distress based on their presentation or their ability to function, that that we consider some of these other external issues, what's going on outside of school that could be that this kid is carrying into school with them,
Hey,
impacting their
Don,
readiness to learn. Yes, Dale.
we have a question, and it is this. For the non-suicidal self-injury, is it ever within the norm these days? They're seeing clusters of students who seem to be feeding off each other with this.
Mm-hmm. Absolutely. We did a webinar on self-harm a couple months ago, and the contagion effect on self-injury is enormous. And it's one of the and this is purely speculation because there's not a lot of research on non-suicidal self-injury, but the reason that it's pushing down to younger grades is that it's as kids start to kind of attach themselves to social groups based on a shared interest. It's where all the baseball players hang out with the baseball players, and all the girls are hanging out with the girls. The kids on cheerleading are hanging out with the cheerleaders. Gymnasts are hanging out with the gymnasts. Well, now self-injury has become a social identifier. About 10, 15 years ago, we started to see it more in middle school, and now it's starting to emerge in elementary school, where one kid will be experimenting with this behavior, and it gets picked up by other students. So you can have a whole social cohort of kids that are together and socially interacting just based on the fact that they're self-injuring. Now, typically, they're not necessarily sitting around comparing their scars and things like that, but what they're doing is sharing their emotional angst and pain, and maybe talking about how they injured, but not necessarily sharing what their injuries look like. It is certainly something to be aware of, and certainly if you have questions of more specific questions about how to intervene with that, or what can you do about it as a school, I'd be happy to consult with you on that. At the end of the presentation will be my email address and phone number. I'd be happy to talk to you about it, about your particular case. It's for better or worse, a lot of times these kids have to age out of the system because these social cohorts tend to be pretty toxic, but also tend to be pretty persistent. And so sometimes difficult to kind of root out, and a lot of times you have to wind up identifying who the one or two or three kids that are primarily engaging in this, and that it's a more serious issue, because those are the kids that tend to sustain this sort of social contagion. A lot of kids are just trying it out for size. They may do it a few times and decide it's not for them. Which is most kids, honestly, but there are some that this behavior will persist, and they'll draw other people into it to kind of support their own behaviors. So sometimes it's a matter of identifying who those primary people are in that social group, and usually it's two or more that are primarily engaging with each other, and kind of separating them out. It can be if possible, can be helpful. So it's a good question, and like I said, we can take up a lot of time on that, but there is I'd be happy to take the discussion offline with you and see if there's some other advice I could give. Okay, let's see here. There we go. So schools are the most universal natural setting. There's 55 million youth in school. Almost 7 million adults work in schools. So at any given time, between the months of August and June, about 20% of the U.S. population can be found in schools during the work week, which is pretty significant if you think about it. Somewhere between 20 and 38%. Again, the statistics are so highly variable based on the study you look at, based on how the study is completed. But so if you look at several of the studies, the percentages range between 20 and 30%. 38% of youth have a diagnosable mental health disorder. The general population is 1 in 10, and that covers the whole gamut. So what this tells us is that our youth are more vulnerable and more likely to be symptomatic with a mental health issue. About 10% have have more serious symptomology that impacts their daily functioning, their ability to function in their main role, which is being a student. But only about, I think a third is a very high number, and it depends on what you define as treatment. If you define treatment as getting ADHD medication from a pediatrician, then sure, a third is probably more close to the truth. But that's still saying that only 1 out of 3 kids with some sort of issue receive any treatment. So the schools provide a universal setting, and using good RTI language at the universal setting, we have an opportunity to impact and identify students that are dealing with issues that we can then either put some interventions in place or get them connected with a resource in the community. Certainly, there's workforce issues. There's a fairly high turnover rate in Illinois in particular. This is national data that there's that teaching is a high burnout profession, and we're seeing it more so here in Illinois, as we're all being asked to do more with less. So I suspect these numbers are probably even higher for Illinois schools. One of the things there are some opportunities we have in schools for for students that are suffering from a mental health issue. We can observe kids in a natural setting, so we can observe them in what's supposed to be their primary role and see how they're functioning in that area. We can, schools have an opportunity to identify students that are silently suffering, so to speak, where they're, this is over time you can say, well, this kid just doesn't reach out, this kid isn't being social, this kid doesn't have a peer group, this kid tends to fade into the background, what's going on. And again, using good RTI language can provide 3 tiers of service: universal, selective, and indicated. Meaning that you can having good, for lack of a better term, mental health hygiene in the schools at the universal level, and being able to identify those kids that might be dealing with a particular issue and connecting them up with perhaps a support group at the selective level, or those that are having significant impact from their symptoms that you can make a recommendation or referral and discuss with the family about getting connected with a community resource. And schools have the opportunity to reach out and have, make that connection with families, with the students, with the youth, individual youth, and other school staff to be able to collect enough information to be able to effectively intervene. So DSM.
Hey, Don, I want to add to that last slide that you just were talking about. I just recently was doing some research on suicide and SAPs, and I found a study that actually said that students who are suicidal were who died by suicide at double the rate if they were not involved with an SAP.
So that if there was not some sort of student support team that was kind of in place and intervening, that the rate of suicide was higher.
Yes, almost double.
Wow. Okay. So that's significant. We have such a they spend so much of their lives, for lack of a better term, in schools, and with the amount of two-parent working households, with the number of kids that are overly scheduled in activities outside of school, the school is really in one of the better positions to identify when a kid is dealing with is suffering from a particular issue, and is in a best position to identify and refer and intervene. So let's see here. So just to touch base about the DSM, the DSM is the Diagnostic and Statistical Manual. We're currently in version 5, which has not yet been fully implemented yet. We're still working in a lot of ways with the DSM-4. It was put together by the APA, American Psychiatric Association, to, the first one came out in the 60s, but the goal was to have a manual that contained all the diagnosable mental health disorders and what their criteria for having those disorders are. It was to develop a common language amongst those that provided care and treatment. So each diagnosis has fairly specific criteria that someone has to meet in order to be diagnosed with that particular condition. So as we talk about different conditions that one of your students might be experiencing, there are specific criteria or benchmarks they have to meet in order to, if you suspect a depression, what does that mean, and what kind of criteria are we looking at? So, so here's a little cartoon about how a lot of our kids present. It's a lot of them. How are you doing today? I'm okay. How was school? That was fine. You doing okay? Yeah, I'm okay. I suppose. We deal with, especially with our adolescents, we deal with a lot of single word or two-word answers to questions, and we have to kind of suss out what's going on based on some limited feedback. So there's three. We're talking about depression or depressive disorder. We're talking about, there's three major categories of depressive disorders. There's a major depressive disorder, there's dysthymic disorder, and there's, we see a lot of these depressive disorder, NOS, are not otherwise specified. What that means is that in most diagnostic categories have this NOS catch-all. It means that it doesn't neatly fit into some other category. So so we have this kind of catch-all for most of the diagnostic groups. So depression, about 2.5% and up to 5% of adolescents suffer from a depressive disorder. For children, it's fairly even between girls and boys. However, in adolescence, you see a marked increase in girls being diagnosed with depression. and gone untreated, a major depressive episode can go on for not weeks but months. And it's a fairly high rate of reoccurring after an initial one is resolved. One of the key things in looking at whether or not someone might be suffering from a depressive disorder is getting a good family history, and that's really kind of in looking at determining if someone might be dealing with a particular issue. Is getting a sense of what the family history is with different mental health issues. Having a parent that has suffered currently or by history with a depressive disorder is the single biggest indicator that a child will have one themselves. One of the the side impacts of the development of specific antidepressant medications, in particular when Prozac hit the market in the 80s, is it was very targeted. It had a lot fewer side effects than some of the older antidepressant medications. So the people on these medications were getting relief from depression long term, which was fantastic and great for their health and their functionality, and their ability to form and maintain relationships. So one of the unwanted side effects of this has been that those that suffer from depressive disorders or other disorders, but in particular depression, have been better able to develop a relationship with another person, get married, and then have children. And now these children have been entering into our school system for the past 15, 20 years or so. And so we've seen a fairly remarkable uptick in the frequency of depressive disorders and other disorders like bipolar disorder in our youth. And that could be one potential reason for it, is that medications are great and they make people more effective and functional, and also allow them to engage in longer-term relationships that could result in having children. So I'm not going to necessarily read through all of these, but the thing about diagnostic criteria is there tends to be a whole laundry list of them, and if you meet a number of them, boom, you've got the disorder. So the thing about major depressive disorder is that the symptoms have to persist for at least 2 weeks. So after 2 weeks, if someone is still having problems with a depressed mood, not eating, resulting in possible weight loss, having trouble falling asleep, staying asleep, feeling lethargic. One of the things that we see with adolescents and children, but particularly adolescents, is that depression exhibits itself, it expresses itself not only in a depressed mood, but also in an agitated mood. So students that are angry and acting out may not just be, might not be dealing with a conduct disorder or oppositional defiance. They might actually be depressed, and it's expressing itself as agitation. So the not only is it some of the benchmarks is not just having 5 of those, that laundry list of symptoms, but also that those symptoms are impairing somebody's ability to function, or to impair their primary life role in functioning. Dysthymia, it's a depressive disorder, but not typically seen very often in children or adolescents because of the length of time. Dysthymia tends to be a kind of a low-grade depression that lasts for a significant amount of time. Is just ongoing. Major depression tends to come in episodes. Those episodes can last weeks or months, but dysthymia, that low-grade depressive episode persists for a year or more. So to be diagnosed with dysthymia, it has to impair functioning for at least a year in kids and adolescents. It's 2 years for adults. So what are some signs or some symptoms? What can it look like, depression? Negative thinking, a lot of negative self-talk. I can't, I won't, I'm not able to do it, I'm worthless. Socially withdrawn, isolating themselves. Someone who might have been had a group or cohort of friends now doesn't engage with them or hang out with them. Again, we talked about irritability. Poor school performance, not just grades, but attendance, engaging in extracurricular activities as they had previously. Lack of interest in peer activities, somatic complaints, muscle aches, lack of energy, not just lackluster, reporting feelings of helplessness, like that they can't, reporting that they don't feel like they have any control over the situation or don't have the ability to change their situation. Again, lower confidence, negative self-talk. Acting out, getting into trouble is another possible sign. So what things work for depression? So psychoeducation is educating an individual about their condition. Just like education is helpful for those that suffer from diabetes, and understanding their condition, that can be helpful for depression as well, and understanding that they can exert some control and recognizing when their symptoms are getting worse. Cognitive coping, so this comes out of a group of a theory called cognitive behavioral therapy. So learning skills to cope with the symptoms and recognizing them, problem solving, activity scheduling, kind of keeping busy, and working against that tendency to isolate, skill building, social skills training, communication skills. These are all things that have been proven to be effective for addressing depression. So cognitive coping. This is CBT, or cognitive behavioral therapy, has the research has shown is the treatment of choice for mood disorders, particularly depression. It's proven time and again to be effective in reducing symptoms and increasing functioning. So some things that you might be able to help the students out with are helping them change their cognitive distortions. What are cognitive distortions? That means that their view of the world or their view of events is distorted. So a fairly common distortion is, my teacher gave me a D on this test. They must hate me. Or gosh, that person gave me a funny look. They must be talking about me behind my back. So these are some fairly common cognitive distortions that, for someone with depression, those distortions might be, my life is horrible and there's nothing I can do about it. I'll never amount to anything. So helping them recognize that some of the thoughts don't match up with reality. That can be helpful. Helping them change the direction of their self-talk from negative to positive, and helping them identify what things can kind of trigger those cognitive distortions or those irrational thoughts. So if it's gosh, that teacher's got to hate me, is it getting a grade back? Is it in particular how they react to a typical interaction with a teacher, things of that nature. Help them become aware that they're having these thoughts, that these irrational thoughts are coming, and how to identify when it's rational or irrational. Again, getting rid of negative self-talk, the always and nevers are helpful to point out that always and never typically are irrational thoughts. And then encourage them to believe the positive self-talk, that it's practice. You may have spent weeks or months engaging in negative self-talk and begun to believe it or see it as true, even if there's no evidence that it is true. So they may be uncomfortable with positive self-talk, but to encourage them to continue to do it until they begin to believe that rather than the negative self-talk. we talked a little bit about what some cognitive distortions are. So exaggerating, filtering, labeling. Exaggerating, making, the nothing, never, everything, always. Those are some key words to pay attention to. That following thought is irrational. Filtering, filtering out the positive things just to focus on the negative, and then labeling. So if they're in a home environment where there's a parental figure that's refers to them as being stupid, even though they may have average or better than average intelligence, they begin to think of themselves as stupid and label themselves as stupid, and will comport themselves in that way. Discounting, rejective positive experiences is not important. Well, you got an A on this test. Yeah, but look at all these other tests I got C's and D's on. Catastrophizing, worst case scenarios. Always looking at worst case scenarios, and then holding themselves responsible for an outcome that was not even into their control. So these are some fairly common cognitive distortions that you can help point out to them and say these aren't rational. Let's come up with some different thoughts. Anxiety. Anxiety is certainly one of the most common mental health issues that our children and adults deal with. So under anxiety we have panic disorder, which tends to be a highly agitated state. Obsessive compulsive disorder, which is where someone has repetitive thoughts that can lead to compulsive or repetitive behaviors in order to alleviate that obsessive thought process. So this is the kid that's afraid that there's germs everywhere, and if they touch someone else's hand or shake someone else's hand, that they're going to get seriously ill. And if they do wind up touching someone else's hand, they might have to wash the hand 13 times in order to make sure that they're not going to get ill and die. Specific can be very very debilitating. Specific phobias, it could be something basic like a fear of heights, all the way up to school anxiety and school phobias, which can be severely debilitating to someone's ability to engage in the learning process. Separation anxiety, we see this more with our younger kids. Again, these are the kids that might be peeling off their parent at the front door on a daily basis. And usually in these cases the parent is also dealing with an anxiety disorder themselves. Post-traumatic stress disorder for a kid who has suffered some form of trauma. That trauma may result in some ongoing symptoms, and PTSD falls under is an anxiety disorder. And then generalized anxiety disorder is that catch-all, kind of like depression, NOS. It's pretty prevalent. So about 1 out of 10 or more than 1 out of 10 kids will have an anxiety disorder. Girls are more affected than boys, and about half the kids that are dealing with an anxiety disorder, about half of them will have a second anxiety disorder or some other form of disorder such as depression. Anxiety and depression often go hand in hand. So it's if you've got one going on, there's a chance that there's something else going on as well. Let's see. So as we talked about traumas, and we'll be talking more about trauma at next month's webinar on the 13th, but some of the impacts of trauma on learning: decreased IQ and reading ability, lower GPA, more absences, decreased rate of high school graduation, and more acting out that typically results in higher levels of suspensions and or expulsions. So trauma, unresolved trauma can have a very significant impact on symptomology and a kid's ability to function in school. So what are some things that you can do with an anxious kid? Modeling, so it's modeling what's a non-anxious response and promoting their imitation of it and practicing those. Relaxation techniques, so anxiety causes an agitated state physically, increased heart rate, increased respiration, so teaching them to have use a relaxation technique to lower their excited physical state can help reduce the anxiety as well. Deep breathing is something that they can do if they're starting to experience that anxiety in, say, a classroom setting, because they can do it without drawing notice to themselves. These are some techniques for deep breathing exercise. Or using mental imagery or visualization. This is helpful, doing a guided imagery exercise and having them cueing them to remember this guided imagery state that they can go back to by closing their eyes, engaging in some deep breathing, and going back to that scene, so to speak, that's peaceful and serene, and will again calm their excited physical state and therefore reduce the anxiety. And then progressive muscle relaxation is something else that they can do without drawing attention themselves in the classroom. So alternating progressively state of tension and relaxation can help them cue in on which part of their body might be experiencing the most tension, which can contribute to the anxious state. ADHD. So we have a few minutes left. I do want to hit this because this is the third major thing that you're going to be running into. The prevalence of ADHD, the studies are all over the place. It certainly does affect more males than females, but we are seeing a fairly significant number of females that have diagnosable ADHD. Unfortunately, this is one of the most overdiagnosed conditions that we deal with in the school setting. There are far fewer kids that meet the clinical criteria for ADHD than have been diagnosed with it. So,
Don?
There's yes.
I know we're running short on time at the hour, but what
Yes.
I would like to do, if you're amenable to that, is to go ahead and have you go through the rest of your presentation, and then we will have it obviously recorded and archived on our website. So if anybody does need to leave, they can access that then on our website and continue where they left off.
Sounds good. So just to return to ADHD, so the DSM, the main things that they're looking at is if there's a number of areas that they have difficulty holding attention, that there's a number of areas that they are hyperactive or impulsive with, that it persists for at least 6 months, that it's not just a short episode. And that these symptoms, these behaviors are impairing them socially, academically, or occupationally for those that are adults. That their behaviors are not consistent with the developmental level that they're at, age-wise, and that the onset typically, that the symptoms have been causing impairments starting prior to the age of 7, because after that it might be something else. And that the impairment is present in 2 or more settings. If it's just happening in school or just happening at home, it doesn't meet the benchmark for ADHD. This is something that doesn't stop when they hit the door at home, or it doesn't start when they hit the door at school. If it's just in one area, then there's more likely some environmental factor going on that they're acting out with. So inattention. So if they're experiencing 6 or more of these symptoms of inattention in these areas, that's good criteria for attention deficit. With the hyperactivity, if they're hitting most of these, then it's that differentiates ADD, attention deficit disorder, from ADHD, attention deficit hyperactivity disorder. So it's the hyperactivity and impulsivity that really adds that H to the diagnosis. So not just hyperactive, but also impulsive. And again, it's, make sure it is ADHD, because there are a number of things that it can be other than ADHD. That's where good, a good evaluation or good testing comes into play, rather than just a single trip to the pediatrician who says, well, it must be ADHD. Let's try some Vyvanse and see how it goes. It can be much more complex than that, and often is. So getting a good differential diagnosis, going to someone that is well versed in ADHD diagnosis, well versed in differential diagnosis. If it's not ADD or ADHD, what is it? This graphic shows some other issues that it might be. I mean, it could be very well age-appropriate behavior. Kids just might be acting out. They may be just attention-seeking because mom and dad are attending to them at home, so they're engaging in non-prosocial behaviors. It could be that there's pervasive developmental disorder, or there might be sensory deficit, sensory processing deficit. So there's any number of things that it could be that these symptoms occur, but it's far too often that this label is slapped on the situation, and a kid is medicated inappropriately and can cause an exacerbation of symptoms. So if there's not some good testing or good differential diagnosis, it can actually create a worse situation for that child. So if there's not been, if you have a kid coming in that being presented for a case study that has an ADHD diagnosis, take a real good close look at where that diagnosis is coming from, and if it's not coming from someplace that's done some good testing, good solid testing, or good differential diagnosis, then encourage the parents to seek out that service to make sure you're dealing with the right thing. So what doesn't work for ADHD? So these are some treatments that have been shown to have little or no effectiveness. Special elimination diets, vitamin regimens, gluten-free diets, vitamin or other health foods. Psychoanalysis and psychotherapy are not particularly effective for ADHD. Biofeedback is not particularly effective. Play therapy, going to a chiropractor, social skills, self-control, sensory integration training are typically not very effective for ADHD. What does work for ADHD is good behavioral interventions. These are despite their condition, and with even with or without medication, someone can learn how to moderate the symptoms of their attention deficit disorder if they're getting some good behavioral interventions. So for the school setting, clear and brief rules, concise. Not a laundry list, and not a huge amount of specifics, but just clear and brief rules and limits. When someone steps outside the rules, that the consequences are swift and immediate and frequent. So if they're if the box that they're kind of put in from a limits perspective is pretty small, then the consequences have to be consistent and frequent and powerful enough to get their attention. Conversely, if there's that they also have to be incentivized for when they're engaging in appropriate behaviors, and those incentives and rewards have to be changed up over time. It can't be the same thing over and over. And as a group, you have to expect that there's going to be failures, and if you can anticipate, for instance, if there's a particular time of day that's more challenging for a student, oftentimes it's the afternoon after lunch. Their energy level is dropping. They're it's harder for them to concentrate, and they're more likely to act out, then anticipating that might be a time of day that you may not want to challenge them academically as hard, so to speak. Praising correctly increases compliance in youth with ADHD. So it can be verbal praise or encouragement, attention, affection, physical proximity. So when you want to catch them doing good, you want to catch them doing what where you're guiding them towards as far as your behavioral intervention. So it's not just catching them when they're wrong; it's catching them when they're good. It's much more effective with this population. And the praise has to be effective. Be specific. I like you did a good job at not interrupting when Johnny was speaking. So it's very specific, not just, hey, you did a good job there. Be specific in your praise. Be honest, but not overly flattering. Don't use backhanded compliments because that just undoes any praise that you might have just given. And the praise has to be immediate. You can't wait until the afternoon saying, hey, you did a good job in the morning. It has to be immediate. Your staff and teachers you have to reinforce. You have to be selective, and we're going to intervene. If there's mild unwanted behaviors, you want to ignore those because they're not necessarily going to be effective to intervene on each and everything that they do. But by ignoring the mild ones, you perhaps will reduce their reinforcement. So you want to attend to and reinforce their positive behavior. So if there's something else they can be doing, remind them of that, and reinforce and praise when they do engage in those more desirable positive behaviors. How do you ignore a kid when they're engaging in a mild unwanted behavior? Once a child starts engaging the behavior, don't look at them. Don't attend to that behavior. And don't look at the child until the behavior stops, barring, of course, that there's a safety issue. Postural cues: turn the front of your body away from the location of the child's undesirable behavior. So turn your body so you're not facing them, so to speak, with your body. Don't appear frustrated. Be attentive to your body language. Don't change the frequency or intensity of your current behavior. So don't talk louder or faster to try to get their attention, because that's attending to that behavior and will reinforce that behavior. Maintain a calm voice, even if they're acting in a way that you don't want them to. Don't speak louder or faster or try to shout over the child, because that will not be effective either. And continue with your activity, even if the undesirable behavior begins. Continue what you were doing, and don't panic. Don't draw more attention to that child if he or she begins inappropriate behavior, because that will draw attention of the other students to that behavior, which will again reinforce that behavior. So when to ignore it, it's if they interrupt conversations or class, blurring out answers, mild tantrums. Don't ignore it if that undesirable behavior could potentially harm the child or someone else. So safety, of course, is always a primary concern. You want to make sure that they're not acting in an unsafe way. But if for these mild things as interrupting or blurting out or mild tantrums, engage in the ignoring behavior. So again, step one is to ignore. Step two is reinforce the desirable behavior in a systematic way. So if for an example, if the target behavior is interrupting, the desirable behavior is working by themselves. If a child goes 5 minutes without interrupting, they receive reinforcement, praise, attention, things of that nature. If they interrupt before the 5 minutes is up, the 5 minutes restarts. So the types of disorders that have disruptive behaviors is typically associated with them: ADHD, oppositional defiant disorder, which tends to be very argumentative with adults, easily annoyed, actively defiant, loses temper very easily, and then conduct disorders, which tends to run more along the lines of aggression towards peer, destructive, deceitful, tends to break rules for the sake of breaking rules. So here's a little cartoon so an oppositional defiant kid, of course, that there's somebody, at least car in the driveway, being inappropriately confrontative with a parent, for instance. ODD, oppositional defiant, the diagnostic criteria having 4 of this laundry list. So again, loses temper, argues with adults, spiteful, angry, things of that nature. It's much more prevalent in boys than girls. Prevalence is, again, the studies vary about 3 to 10%. The oppositional defiant disorder is fairly is significantly predictive of a chemical dependency issue. So those with ODD, almost half develop a chemical dependency issue as they emerge into adolescence. So one of the things to look at as possible comorbid issues are ADHD, depression, anxiety, and learning disabilities. So conduct disorder, this tends to be much more serious, aggression towards people or animals, deceitful, again, destructive, again, breaks rules for the sake of breaking rules. Prevalence is less. It's 2-3%. Boys far more outweigh girls with this particular issue. Half of them typically have a learning disorder or an ADHD. Most people with a conduct disorder, it will remit by 2 years. Will have a spontaneous remission by the time they reach adulthood. Typically, the societal rules is enough to kind of shape this disorder out of a kid. But those that don't can develop into antisocial personality disorder, which is a fairly serious thing, and what we see in those that are frequently involved with the court system. Early onset would be before age 10. Regular onset is after age 10. For the disruptive behavior disorders that we just talked about, things that work on praise, commands, and limit setting, very frequent limit setting, tangible rewards, response cost, psychoeducation, problem solving. The education problem solving tends to work better with the older kids, or whereas the limit setting, tangible rewards tends to work better with the younger kids. So it's in setting limits and giving directions to kids with a disruptive behavior disorder. Make eye contact before giving a command. Make sure that they're able to see you, and make eye contact that they've made that connection, and then give the direction. Reduce other distractions while giving commands. So if it's necessary to kind of bring them to a quiet corner of the room or a quiet area in the room to give that command, that might be necessary. Ask them to repeat it so they know that they heard and understood it, and attend to them for a minute after giving the command to ensure that they're complying, and to praise the child when they're complying with it. And with adolescents, it's a little bit different. Praising teens for appropriate behavior. Tell them what to do rather than what not to do. So let them know what the expected behavior is, and ask them to do that rather than hey, stop doing that. That's not as effective. Again, eliminating distractions while giving commands. Break it if it's fairly complex what you'd like them to do. Break it down for them. Use aids that involve time. Present the concept. Let them know what the consequences are if they choose not to comply with the direction. Let them know ahead of time. So this way, you're presenting them that they have the choice whether or not they experience the consequence. And don't express gratitude if they're being compliant. Don't say, "Oh gosh, thank you for doing that." That's not particularly effective. And then reward system for it could be a token economy. It could be stickers. Kids love stickers for some reason. I think that can be an effective reward system. And it's good to be able to partner with parents to continue that reward system at home and have some consistency. That can be very helpful in getting them to alter their behavior both at school and at home. And to remember that when there's acting out, that their acting out has a cycle, and that there's only a certain period of time that someone can sustain that, without something contributing to sustaining it, sustain an acting out behavior. So the point to hopefully that the student will be able to identify a time with some guidance and help is what triggers that agitation. And if someone is agitated, if it recognizes signs of what agitation looks like in that particular child, and hopefully intervene at that point rather than let it continue or exacerbating it, so it turns into a more significant acting out episode. So it's recognizing a sign of agitation early before it can reach its peak, because if you get to that peak, they're not rational at that point, and trying to engage with them rationally is not going to be effective, and you just got to wait for them to hit that de-escalation phase where they're more open to feedback and discussion about what triggered them and what they can do differently next time. So some general strategies, again, use active listening. Don't be afraid to show that you care. Be a good role model. Greet students daily and show some genuine interest in them. It's having that connection is important to be able to engage with them and when looking at trying to intervene and do things differently. Again, find the strengths, find the positives. Move beyond the labels, because the labels can be helpful, but they can also be damaging if overgeneralized. Problem solve, smile, be involved with the families, because they're a great source of collateral information and can help reinforce what you're doing at school and vice versa. And instill hope. Let them know that things can and will get better if they're willing to put in the time and the effort. And that concludes the presentation. As I said, this is my email and address and phone number. Feel free to contact me if you have any questions about the presentation or the materials. And as I mentioned before, in May, on the 13th, we'll be talking more specifically about PTSD and grief in the SAGE group. Thanks for your time, and turn it back over to Dale.